Hi, my name is Sharon, and I am one of the urology nurses at Mayo Clinic. And today I will be talking about providing evidence-based practice intervention in response to autonomic dysreflexia during urodynamic study. So a problem we identified was autonomic dysreflexia is a life-threatening complication of high spinal cord injury affecting 90% of individuals. A urodynamics or UDS is a gold standard procedure used to evaluate patients with lower urinary tract symptoms. So common autonomic dysreflexia triggers are bladder distension and UTIs. So autonomic dysreflexia is commonly observed during our urological procedures. Due to the severity of complication, implementing guidelines to help manage AD is crucial. So our objectives was to align our current practice with the American Urological Association, Society of Urodynamics, Female Pelvic Medicine and Urogenital Reconstruction, the AUA SUFA guidelines. The guidelines recommend continuous monitoring of at-risk patients during a urodynamics, immediate termination if the patient shows any signs or symptoms, pharmacological management if terminating was not effective. So our methods, the current department guidelines for autonomic dysreflexia were compared with the AUA SUFA guidelines. The comparison revealed gaps in practice and essential nursing interventions, such as early identification of patients at risk for developing AD, appropriate medication management, staffing considerations for patients, and knowledge deficit among the staff were identified. So we created education for the staff on pathophysiology, signs and symptoms, and appropriate responses. We improved our workup process to identify the patients who are at risk. We ensure there's appropriate staffing to include at least one registered nurse. We implemented a communication pathway for patients identified at risk, created a response workflow, and we standardized the process the day of the procedure. So autonomic dysreflexia, this picture depicts what happens during a response. So your body senses an unpleasant stimulus below the damaged spinal cord. It stimulates a sympathetic nervous system response. This causes blood vessels to constrict in the lower part of your body, legs and abdomen, resulting in a sudden increase in blood pressure. The baroreceptors in the blood vessels detect this hypertensive crisis, signaling the brain to shut down that sympathetic surge and slow the heart rate. But the descending signals are blocked, and the bradycardia isn't enough to stop the hypertension. So this is considered a medical emergency, and the stimulus needs to be removed immediately. So we revised our department workup and workflow process. So the workup process, we have someone review the patient's past medical history. We're looking for any signs of high spinal cord injury. We also review their medications. If they are on a PDE5 inhibitor, such as sildenafil, we know the patient to stop taking the medicine in case we have to give the nitro paste the day of the procedure. We also pen an order for the nitro paste. So the day of the procedure, we ensure that the nitro paste is pended. We make sure that we have adequate staffing, including a registered nurse. We obtain our nitro paste from the Pyxis, put it in our red bin into the urodynamics room. That way, if we need to use the medicine, we have it in the room with the patient. Otherwise, we return it to the Pyxis. Our workflow response process outlines blood pressure monitoring guidelines, also how the nurse is going to assess. And what we're looking for is a systolic blood pressure greater than 20 millimeters of mercury above baseline. We're looking for common symptoms of autonomic dysreflexia, such as profuse sweating, flushing above the level of the lesion, bradycardia, blurred vision. Or also there's silent autonomic dysreflexia, which would be no symptoms other than just an elevated high blood pressure. So the autonomic dysreflexia response workflow identifies intervention for managing autonomic response. So the first thing we would do is stop the procedure, drain the bladder, sit the patient up, monitor their blood pressure. If their blood pressure does not return to baseline within 5 minutes, we administer the 1 inch nitropase to their forehead, always above the level of the lesion. The conclusion is, considering that autonomic dysreflexia has life-threatening complications, we realize that autonomic dysreflexia requires early recognition of symptoms, immediate termination of procedure, and possible pharmacological interventions. So we improved our department workflows to identify high-risk patients. We ensure that there's adequate staffing to include one registered nurse, and we also included interventions to be able to manage autonomic dysreflexia during our procedures. We educated staff on pathophysiology, signs and symptoms, and crucial interventions. Our next steps is that we discuss further reviewing patients' medical history, looking at their bowel program, their UTI assessment, maybe holding any other medications that may elevate the blood pressure. We also talked about formalizing a post procedure patient instruction and developing a simulation trainings for our staff. And here are our references. And that's it.